Okay, good afternoon. I am here in the lab number 4 with Dr. Fava, with Juan, Erika, Alex, Claudio is our tech. Here is Jaime as an anesthesiologist, and Mariano is our anesthesiology tech with crossover from the lab number 1 to here. So let's go with the slides. Las diapositivas. Okay, perfect. So this is case number 6 in our series of cases. So next slide. So she is an 81-year-old lady. She presented with dyspnea. She has history of hypertension, dyslipidemia. She was a former smoker, heavy smoker. She suffered from a hypothyroidism and also a significant COPD. Next. On the ACG, there is under a normal sinus rhythm with 65 per minute. The PQ is 160, but she has a right bundle branch block with a QRS of 160 milliseconds. So this is an important consideration. It's why we are going to use pacemaker from the beginning, and this patient is gonna keep the pacing at least until tomorrow. Carlos, do you agree?
Yeah, I agree.
Okay, perfect. So under the blood test, she's suffering from a little bit anemia with a normal renal function, with normal platelets account, with a body mass index, of 26, and the echo Doppler evaluation unveil a severe aortic stenosis with a significant gradient of close to 60, the peak gradient 35, the mean gradient with an area of 0.7 square centimeters, with a Vmax of 4.0 meters per second, with the left ventricular ejection fraction of 60. She also has a significant MAC calcification with a mild aortic, mitral regurgitation. She has suffered from a mild frailty with a Edmonton score of 8 over 17. She is not fertile for this procedure. The STS score evaluation showed a 2.4% probabilities of mortality undergoing surgery. Next. Proxima. Okay, perfect. This is the angio that we normally perform here. Remember that we cannot perform CT coronary angiography. It's not covered by our health system. So that's why we have to do a regular angiographic evaluation before all the TAVI procedures, especially for these old patients. So she has a quite dominant right coronary artery, huge artery, without significant lesions. Next. So this is the left tree with a normal left main with some calcification, but not significant lesions. Also for the LAD, which is tortuous with probably mild lesion, no more than 20% after this huge second diagonal branch. And next. And this is the orthography that we did because we had a previous CT scan that I will show you afterwards. But in this patient we had before, and we knew in advance that this patient had a low left main and small sinus. So we did this orthography to have a better check of we were observing on the CT scan evaluation. Next. So these are the measurements for the annulus. These measurements were done at the core lab. Close to 20, 19.7 and 25 with a perimeter derived of 22 diameters for the annulus with a perimeter of 71 and an area of 395. So on the right side of the panel, you can observe the coronary ostium height, where the left is 10 point something, 0.8, and the right is quite okay, is 15. Next. Here we have the photos. This is annulus dimensions, 19.7, 25, with an, area derived of 22.4 millimeters for diameter. with a perimeter of 71. And on the right is also an important finding that we have to bear in mind because the sinus are quite small. Sorry for the noise. We are open and preparing the valve for the case. So we are preparing 26. Okay. Okay. Sorry for the noise. So the sinus are 26, 28, and 27, as you observe there. So in summary, she had a small annulus. This is very important consideration for our strategy today. Next. So this is the LVOT dimensions, which is almost similar, 18 by 26. So it's not that big. And we have significant calcification at the sinotubular junction with diameters smaller also, or small also, 21, 24, and 22. This is important consideration also for leaving or not the pigtail after the final delivery of the valve, or retrieving before, and also an important consideration regarding left main ostium protection. Next. So this is the calcification of the leaflets. As you can observe there, it's not significant calcification. In our opinion, we can go direct without dilatation to prevent any damage of the conduction system, to prevent a permanent pacemaker implantation. This is ascending aortic diameter, which are also small, 28, 29, 20, 29. Next. And here are the measurements of the coronary height. Thank you, Claudio. This is for the left is 10.8, probably is on the limit or the border for being acceptable and probably for not being protected. But with this small sinus, with this significant calcification of the sinotubular junction, and the other finding I will show you afterwards, we have decided to protect. The right is at 15.4. So this, I mean, height enough for not needing any kind of protection. Next. So this is the finding that we have to bear in mind for our procedure. Next. So this are the projections, working projections, and on the left oblique with left 14 without any cranial or caudal angulation. And for the near cast overlap view, we are going to use the right one with a caudal inclination of 15. Next. So this is the angulation of the aorta, 46, which is not that important. But there, we have done some measurements of the leaflets, of the left leaflets, which is 12. If we have the left ostium at 11 with the significant calcification of the sinotubular junction, with some, a small sinus, these are the three findings that, drive us to protect the left main, even having a borderline height. So we prefer to be in the safest way. Do you agree on that, Carlos?
Yes.
Yeah, perfect. Okay, next. So this are the vascular access. Both are quite similar, about 6 millimeters in diameters. On the right, we have some calcification on the posterior wall. Hopefully, it's not going to interfere with our puncture and our closure devices. In this case, we are going to use ProGlide, of course. Next. And this is the aorta without significant angulation. In the aortic arc, we have some calcification, but they are distal to the left subclavian, so this is not that important. Next. So here in extraction for use, we are in the borderline regarding the perimeter and also the diameters. Next. But according to all the description I have already done about the annulus, the sinus, the ascending aorta, we have chosen in a different way that you usually decide that when we are in the borderline, we always select the bigger valve or the biggest. But now we have chosen the smaller. We have selected the 26 for all that reason that I have already mentioned and to protect this left main. Next. So in summary, it's an octogenarian lady with COPD with severe symptomatic aortic stenosis. So she already had a very clear indication of TAVI, which was suggested by the heart team. Next. And our plan for today is to do TAVI with the self-expandable valve by percutaneous femoral access. And we are going to protect the left coronary ostium from radial approach. Next. So let's go back to the lab. Dr. Carlos has already done the left radial access. Here we are going to introduce the catheter to protect the left main. Here also have the function on the left femoral artery, and here we have the venous access. Now we are going to do the crossover, and we are going to do the puncture of the right side, which is going to be our access site. We are going to protect as always. So we always try with the pigtail. If something goes wrong, we can use different wires or different catheters, but that seems to be the case. Okay,
We have some mild pericardial effusion anterior, very little.
okay.
So now we know.
Now we know. You know why? If we have this finding after the procedure, say, wow, maybe we have a perforation or something like this. Okay. Okay. Oh, it's okay. It's okay. Let me do some avulsion here. Make a traject here. So then we have a perfect movement of the suture when we finish the procedure. We are going to put the 6 French introducer set. We are going to complete the hyperonization with the full doses. Probably we have to check the zero of the blood pressure because I think it's not right.
Okay. Right.
Now it's okay. Perfect. Now it's right. Perfect. Let's go with the thin wire by contralateral side.
Perfect.
Oh. Once again, we two probe Okay, we are in the common femoral artery. It's okay. We are going distally. Okay. Oh, no, here. Para tu lado. Okay, now we are going to introduce the regular wire for the probe lights. We are going to change. We are also use a ProStar. So we will have 6 sutures because during this maneuver, probably we damaged the artery. See. So now we are going to put the pacing here, the pacing wire here. Okay, we are going to loop a little bit. Everything okay, Jaime? All okay, okay. Now, abajo. Infla. Okay. So this case is from the beginning, just to use all the time we have this hour, because if not, this is the most difficult part in the TAVI procedure, is to put the patient in the right position. Okay. Especially for patients with tricuspid regurgitation, sometimes it's difficult. These wires are okay because they are soft, but a little bit difficult to manipulate. Once again. Okay. Okay, this is important. The distal balloon to prevent any puncture of the right ventricle wall. Okay,
No problem.
Omar, let's go with the 5 French. Turn on off this light. If not, it's difficult for the camera. Perfect. Yeah, no tanto, no tanto. Okay, sí, okay. Okay, now we are going to cross the valve, and then we are going to put this 6 French guiding catheter. So we are going to go from the radial axis to go to the left main. I think it's a little big catheter. Probably we have to exchange. Do you have a cordis guiding? No. Dame eso.
¿Qué fue?
Yeah, because the gut sealer is difficult, or guideline then are difficult to put inside this guiding. Let's go with the long wire. We can exchange. Take it out.
Yes.
Give me an extra support wire. Oblicuo a derecha. Right. Test. Sí. Let me check. Okay, sorry, it's okay. Now I am going to put the wire into the LAD, distal to the left main. I will introduce the guide extension. ¿Qué extensión de guía tenemos? No, hijo.
Decir,
Okay, we are going to use the telescope from Medtronic. Give me one. Valve is ready. La válvula está lista. Okay, valve is ready. We are going to check before starting. Now we are going to introduce the pigtail as a marker.
confía.
I think it's okay. I think overlapping is perfect. The position is great. The pigtail is great. We have the guide in there. Okay, and now let's go with the valve. So I think this is an okay position. Mini test. Okay, a little bit lower. Okay, pacing 120, 120. Okay. Slowly. Okay, let's go. Let's go, Carlos. Let's go. Okay, perfect. Stop the pacing very slowly. And here is okay. I think we are okay. Left main, let me check a little bit distally or proximally in reality. I think it's okay. We can complete the delivery. I will pull back the catheter. Let's go.